temporal mandibular dysfunction, we all see it. We all have our busy days in the clinic. We're working away. We have, probably it's been an ambitious day, lots of patients booked, and then we have the TMD patient who walks through the door, and they just seem to have more and more and more to talk about, and they just require a lot of our time. So if you can get quicker or more efficient with your management from start to finish for one of these types of patients, then it can improve productivity while you're at work, improve production. It can also improve the experience for these patients, because even though they may be some of the more difficult patients to deal with, a lot of the times they're probably, because of that, managed in less efficient ways, and they kind of hop around from clinician to clinician, a lot of times without having any real solutions for them. So this is just a good overview, and it will give you a good sort of an algorithm to follow as a clinician to get these patients into the right people so that they can get taken care of and improve their quality of life ultimately. So, perfect. So the objectives for today are going to be to understand the pathophysiology of TMD. It's a very diverse set of conditions. I'll just talk about all of those. An important one is also going to be to talk about the history and physical examination. These are really the keys that help you identify what's going on for that patient, what's causing their condition, and going through that really detailed history and physical will help you to find a diagnosis, and then ultimately help you to get the correct imaging modalities ordered and all of that. We'll also talk about those things. So the differential diagnosis is really important because sometimes you can miss things. You can see a patient coming through the door, they're talking about jaw pain, and you can really focus on that. And I know that we train to avoid doing that in all aspects of dentistry. You look at the big picture first, and then you narrow down in on what the patient's talking about. But since some of us have a little bit less comfort with these types of patients, it can be overwhelming, and you can sort of overlook other things. And so we'll just talk about that. Again, the TMD imaging modalities, there are a bunch of them. Some of them we see very infrequently, and they can be difficult to interpret. So we'll just have a little talk about that just to get a little more comfortable with it, and then it'll help to remember those things for getting them ordered and getting the proper diagnosis. And then we'll talk about some ways of managing these patients, things that you can do in your own office, non-surgical management techniques, a lot of different things you can do there that can really help them out. Then we'll talk about some surgical options. So this is really where the oral and maxillofacial surgeon comes in. Lots of, you could say, cool surgical techniques that you see during residency. Some oral maxillofacial surgeons choose to continue to do these types of surgeries after. But it's fascinating stuff, and so we'll just take a quick look at that as well. We won't spend a lot of time on that, just show some fun pictures, because it wouldn't be an oral surgery talk without cool surgery pictures. And then just finally, to help get that patient into the right specialist or person to take care of them, we'll just talk about some of the things you can do to really tee that patient up for a smooth transition to the specialist, and then quicken their treatment or shorten the amount of time it takes for them to actually get their condition corrected. So this is, I guess, your prototypical TMD patient. You can sort of make the diagnosis from across the street. Large jaw, clearly some parafunctional habits going on here. It looks like probably had some attrition, and he's got some type of overdenture on the top and bottom. So this is, it's almost easy to make a snap diagnosis for this type of a patient. But then you also have the patients, the 15-year-old petite girl who has similar set of complaints, and it may not be as straightforward. So you kind of have to think about everyone, and that's what this will help with. So just understanding the epidemiology of TMD. Some patients will say TMJ, temporal mandibular joint. That's kind of like saying I have TMJ is like saying I have elbow or I have knee. You're talking about a joint. But when they actually have pain and symptoms, that's when it becomes a dysfunction. So the correct terminology is temporal mandibular dysfunction or temporal mandibular joint dysfunction. And the literature will say that up to 40% of adults will have TMD, but only about 5% or so will actually seek treatment. So the ones that will seek treatment are obviously those that will be symptomatic in some sort of way. And usually that's pain. And the asymptomatic folk, some of those will get better on their own without having treatment done. And I have a little more of that later on, talking about some of those numbers. But again, the peak incidence you'll see from around 20 to 40 years old. Females have a slightly greater predilection for this condition, or for this umbrella term for a variety of conditions in this area. Multifactorial etiology. So again, in the next few slides, we'll see some of those things that you should be thinking about and asking about during your history with the patient, and when you're doing the physical exam as well, just keeping those things in mind. And again, a heterogeneous group of conditions, we'll go over those. But really the biggest thing is you have two categories, the extraarticular and the intraarticular. And really that's as simple as it needs to be, or as complicated as it needs to be. You have those things going on within the joint, and then everything else is the extraarticular. And so we'll talk about that. And the big thing here, and the important thing to consider, is that not only do TMD conditions affect patients individually, at the quality of life level, but it also causes them, financial hardship. Is a lot of these patients are unable to function, and they have to skip work, and some of your own staff may have a condition like this, and so they take time off work, and so really it's a lot of different areas that can be affected by TMD. So again, most common forms that we'll see in the clinic are myofascial pain disorder, disc derangement disorder. Again, you can kind of classify those as painless versus painful, osteoarthritis, and then you have autoimmune disorders, rheumatoid arthritis, systemic lupus erythematosus, Sjogren's syndrome, all of these autoimmune conditions that can focus in on specific joints, not just the temporomandibular joint, but you can see them in the elbow, the knees, shoulders. But sometimes patients or other clinicians, medical doctors for that matter, can forget that we have two joints in the jaw that need to be considered, and pain from these conditions can also present there. And then we have the more dramatic things, so acute dislocations, trauma with condylar fractures, or intracapsular hemorrhage, and then the most or the least common rather would be neoplasia. So a bunch of different conditions that can present within the joint or around the joint and cause discomfort for patients. So when a patient is then seeing a dentist, a family doctor, sometimes you can see something that looks to be, again, sort of a snap diagnosis, such as this patient here, arrow through the cheeks, and the family doctor there is saying, well, it looks to me like this is what's causing your discomfort, but maybe you'd want to see your dentist. And it's a bit of a tongue-in-cheek humor there, but it's a good point to remember, because some of these things, they look obvious, and if you don't do a thorough job of looking everywhere else, then you can miss things and delay treatment for them. So coming down to the evidence-based side of things, I gave this talk to a group of family doctors actually during medical school and residency. And the idea with this presentation at that point in time was really to sort of give the family doctors an understanding of what we as dentists see in the clinic, and how they can get those patients in to see us, where we can really help them through this condition. Because when I was doing my oral surgery residency here in London at Western University, or University of Western Ontario, and we go through medical school, and a lot of my colleagues that I worked with, they just had no idea what was going on in the mouth. They didn't know how to number teeth. They didn't really know how many teeth people had. They didn't understand just basic things that we learn in dentistry. And so it is important to have that two-way communication between general practitioners in medicine and all of us practitioners in dentistry. So they like to see a lot of these studies, and so I included that there. And then I realized that this is a perfect talk. I mean, everything should be evidence-based. And I found with TMD that sometimes there's a lot of, or there's a bit of a lack of an evidence-based approach to certain treatments. And so yeah, it's important to focus on that. So here's an example here with this paper, depressive and anxiety symptoms as risk factors for TMD. This was just an example of how, with this prospective cohort study, there were about 2,000 participants, and they identified, I think, a twofold risk in TMD in patients who had depression, and then a 1.8-fold risk, increased risk for specifically myofascial pain disorder in patients with anxiety. So this is an example of social and cognitive factors that can lead to an increased risk for this. So very, very interesting. Here's another one, focusing more on environmental factors that can increase TMD. And this was looking at young adults who smoke cigarettes, and they found that there's an increased risk for TMD in women around 30 years old who smoke cigarettes. So you don't necessarily think of these things, but there's a broad range of things that can lead to these types of conditions, and it's important to address those things when you're managing these patients, and so that's why we're talking about them here. So we'll get to that a little bit later as well. But classification of TMD, again, it can be simplified as extraarticular and intraarticular, and just if you keep that in mind, it makes the examination and the history taking a lot easier for you. So with extraarticular disorders, you're looking at everything outside the joint. So you're looking at the muscles of mastication, you're thinking about the nerves in the area, you're thinking about the other anatomy. So you have salivary glands, think about, you have things inside the mouth, even the teeth in a tooth abscess, you have the maxillary sinus. There's a whole bunch of different things. Again, I'll show that in the next couple of slides. But for this one right here, we can talk about local myalgia, so just pain within the muscles of mastication themselves. It can be from overuse, and that can be, it can progress to a myofascial pain disorder where the fascia overlying the muscles can be inflamed and sore. Then it can go to something such as myofibrotic contracture, where chronic inflammation in the fascia and the muscle can lead to those little fibrous bands that are much more difficult to break up, and it can become more of a chronic condition for them. And then there's just inflammation within the joint or within the muscles with myositis, or spasm within the muscles, which we've all experienced after, Vic Jindal, I'm sure after his 5K run this morning, is having some of the myospasm in his quads and hammies right now. But that can also affect the muscles of mastication. And then we can have neoplasia. So you can have neoplasia within the muscle, things like a rhabdomyosarcoma, very uncommon, but still something that, it should be at the very back of your mind when you're looking at these patients. Or it could be neoplasia elsewhere in the joint. It can also be a factor. It can be in the salivary glands nearby, a lot of different things to consider. So for the intraarticular disorders, again, this can be something that's congenital or developmental. So if we think about those first and second pharyngeal arch disorders like Treacher-Collins syndrome, those dramatic pictures of patients that we all saw in dental school on our oral surgery classes, or hemifacial microsomia, really affecting the joints themselves, which can cause a lot of dysfunction. Degenerative joint disease, so something such as rheumatoid arthritis, osteoarthritis, where the joint wears down and the dysfunction gets progressively worse. Disc derangement disorders are important to consider. These are, again, the disc derangement disorder is what we see a lot of the time. We feel for the popping and clicking in the joints when we do our examination. And again, we really have those two sets of patients. There's the painful or the symptomatic disc derangement patients, and then there's the asymptomatic disc derangement patients. And so that really, if you have an asymptomatic disc derangement, there's really not much of a need to intervene for that, at least surgically, but we'll go over that a little bit more later. You can have infection inside the joint. Again, neoplasia. Lots of different conditions that can affect the condylar head or the cartilage at the head of the condyle. All those different tissues within the joint, the temporomandibular joint, have the potential for neoplasia, and they can present in a variety of different ways. Joint hypermobility, so laxity within the joint, a chronic dislocation or frequent dislocation. This is something to consider. Joint hypomobility would be something more like ankylosis that can be either a true or a pseudo ankylosis, whether it's a fibrous ankylosis or a bony ankylosis between the joint and, let's say, the zygomatic arch, which can develop after a traumatic incident where the patient has a fracture, for example, of the zygomatic arch, and then you can, with the lack of mobility of the jaw afterwards, you can develop a bony bridge between the condyle and the zygomatic arch. Or you can even have something such as post-radiation fibrosis, where a patient has, let's say, a base of tongue cancer, they're radiated around the jaw, and then the tissues become fibrotic and less mobile, and they're just not able to open their mouth. They can have pain from that contracture as well. And then lastly, there's trauma. So the classic condylar head fracture, a variety of different classifications for how those fractures present, and then the corresponding treatments for those. So all of these are things to consider. So getting into the history of physical examination, this is really, as a general dentist, seeing a patient with any form of TMD, this is really the meat and potatoes. The history of physical, and to a further extent, the imaging, which can be as simple as just the orthomagnetomogram or the panoramic radiograph. That's really the most important part in the private practitioner or the general dentist's office. So first thing you can do is go through the OPQRST. This is the classic mnemonic that you see in dentistry and medicine for remembering all the important questions during history and physical. So the O stands for onset. You want to ask when it started. Is this something that happened within the past week? Is it something that's been going on for 5 years? If it's been less than 3 months, it would classically be classified as an acute condition. If it's been more than 3 months, you would say that's more chronic at that point. So onset. The next P can stand for two things: provocation, so worsening things, or palliation, things that make it feel better. So ask the patient, does this hurt more when you're chewing hard foods? Does it feel better when you're putting ice on it, or you're resting, or you soften the diet? Really important to get those details, because it can, again, help you get down to the diagnosis. Quality of pain is for Q. And this can help rule out some of those other things that can sort of trick you or lead you down the wrong path. So when you're asking about pain, you should ask about, is it a sharp pain? Is it a throbbing pain? Is it a burning pain? Things like that you might find more with intraarticular degeneration for, let's say, sharp pain, throbbing, burning pain. More so on the throbbing side, you might find with the myofascial pain. But something like shock-like pain is a really important thing to ask, because that's going to be more along the lines of a trigeminal neuralgia or any type of neuropathic pain condition that you can sort of erroneously or incorrectly treat as a muscle problem for a while before they get to the proper treatment. R is for radiation. So you just want to really just ask the patient to point to where the pain is. Say, use your finger and just point to the pain. And if they point right in front of the tragus to the condylar head, that's very likely an intraarticular problem. If they point to up by their temporalis or their masseter muscle, and they say, it kind of radiates along that path up to here, then you're really looking at something that's more muscular. Severity is important to keep in mind, and that's something that you can track with follow-up examinations. So just get them on an analog scale, or just from 0 to 10, or a visual analog scale is helpful too. You can do 2 lines and just ask them to write a line in the middle, and you just sort of turn that into a number. But it's generally just from 0 to 10, 0 being the no pain at all, 10 being the worst pain you can imagine experiencing. Where's your pain? If they say, it's about a 2 or 3, then this might be something that isn't as severe. You're going to need to get into an immediate referral with. If it's something like 10 on 10 pain, and they've been dealing with this for 3 months, 4 months, it just you have to document that. And then again, when you see them after treatment, you have that record. Maybe you started them on a night guard, you've gone through some behavior modifications, diet modifications, all those other things we'll talk about in the next few slides. and then they come back and they've gone from an 8 on 10 to now a 2 on 10, you can almost say that you've cured them essentially. So it's important to have that. The last thing, T, is for timing. So you want to ask about time of day. So is it worse in the morning, or is it worse at night? If it's something that's worse in the morning, you might be leaning more towards degenerative condition within the joint. So do they have osteoarthritis? And just as soon as they wake up, everything's stiff, kind of bone-on-bone contact causing pain? Or is it something that's worse throughout the day after they've been eating and chewing a lot and the muscles are becoming more sore? So again, it can help you fine-tune that differential diagnosis. You can also ask timing with regards to when it happened. So did they have a traumatic event 2 years ago and this started right after that? Or did it just sort of happen out of nowhere? With the physical examination, again, you want to go through the standard head and neck examination that we all learn as dentists. You want to go through the range of motion of the jaw itself. So again, the maximal interincisal opening, it's read as MIO, get that measurement, get the ruler out, put that in your chart, because that's going to, again, help with your diagnosis, but it'll also help you to track their progression through treatment. Get those lateral excursive measurements. Just choose the midline between the lower centrals and measure to the midline from the upper centrals, assuming that they're, as long as you have the sort of a standard reference point, then you can measure that movement, and then get protrusion as well. So maximal opening, lateral excursive movements, and protrusion. Again, someone who has a maximum interincisal opening of only about 20 millimeters or so, you're gonna, even if they've had pain and they've said that I have some radiation up along, the temporalis and the masseter region, or in the pterygoids, you feel in the mouth and they're sore, but then they can only open their mouth 20 millimeters, you can have an overlying myofascial pain disorder, but an underlying closed lock or an anterior disc displacement without reduction. So you can have both presenting at once, and it's important to recognize both and manage both. The other thing to consider is a cranial nerve exam. We all do those, we all learn it during dental school, and it tends to sort of fall off the radar when we're seeing patients for tooth pain. But when you're seeing patients for pain that has a, sort of an uncertain diagnosis, the cranial nerve exam, just go all the way through 1 through 12, get them all. Again, that'll help you to remember things like neuropathic pain. It'll also help you to identify anything that could be a potential cancer that has some nerve dysfunction as a result of that. So glossopharyngeal nerve with their swallowing, facial nerve with their muscles of facial expression. So just take a look at those things. So with TMD specifically, pain with jaw movement is going to be the primary thing. You're going to, again, be feeling the preauricular area, feeling in the masseter temporalis. If you feel with the pinky finger inside the mouth, reaching up high by the zygomatic arch, you can feel the lateral pterygoid muscles. Show pictures in the next slide of that. And you can feel down on the medial side of the ramus and feel that medial pterygoid muscle. And just feel those on both sides and document the pain. If there is significant pain with those muscles, you know that there's at least a myofascial pain component or a muscle component to what they're experiencing. It doesn't mean that there's nothing else going on, but again, you want to get that, you want to make that, recognize those things. If you're not finding any pain with the muscles or with jaw movement whatsoever, again, then you might want to start leaning towards those less common things that we kind of touched on earlier, like the potential for cancer, like maybe it's a maxillary sinusitis, other things like that. Again, we have a slide showing that. So just another thing to note for clicking and popping within the joints, about 50% of patients who have these popping and clicking sounds, or even crepitus sometimes, have no symptoms with it. It's normal. I have it myself. I know a lot of people who have popping and clicking in their joints. It doesn't mean that they need to have treatment for that necessarily. So that's also something that's important to communicate with patients. Just, 50% of people have some type of popping, clicking in the joints, actually, fairly normal. But it's when they start to have those symptoms that it becomes abnormal and you want to do something about it. So here's a good picture to show all the different things that we're thinking of looking at when we're seeing the patient. So number one, down here in the bottom left, this is the teeth in the mandible. So if you have a malocclusion, for example, a class 2, a deep bite, or a class 3 prognathic jaw, that puts a lot of strain on the joints themselves. And so you want to take a look at this, and some of their TMD can be coming from that malocclusion, and how they have to work their mouth around just to get their food chewed up into a bolus to swallow. So this is something where you might consider having them see an orthodontist, or for yourself if you're doing orthodontics in your practice. Something definitely you don't want to miss that. There's also the mandible, the maxilla in that area. If the patient has a class 2 occlusion that's skeletal, or a class 3 that's skeletal, then orthognathic surgery might be something that would be good for them. So again, communication between the dentist, the orthodontist, you can set the teeth up into the for patients who would be candidates for orthognathic surgery. Your orthodontist will set the teeth up into the decompensated position, and then the surgeon can go in and set those jaws to the perfect harmonious position. And you don't say to patients that this is going to 100% relieve your symptoms of TMD, but it is something that can help it. You don't want to sort of sell your treatment as a way to fix TMD. Sometimes orthodontics or orthodontic surgery can make TMD worse, but it is something to consider and to sort of have a discussion with the patient about. So 2, we've got the temporalis and the masseter muscles shown here, and then on the cutaway picture, we can see the lateral pterygoid with the superior and inferior heads, and then down here we have the medial pterygoid going down to the medial aspect of the ramus. So it's important again to just sort of get some fingers palpating those muscles, just to feel for any sensitivity and pain on palpation. And then 3, lastly, is the joint itself. So you have the articular eminence, you have the condylar head itself, mandibular condyle, you have the mandibular fossa with which the condyle articulates, and then you have the intervening or the interpositioned articular disc. And in this picture here, the disc is in a normal position, and then we'll see some images later showing the abnormal position and how that's affected when closed versus when the mouth is open. You also want to think about the retrodiscal tissues. They're highly vascular and innervated, so you get a lot of discomfort from, for example, an anterior displaced disc, which stretches that tissue out, and when the patient's closing down, or their mouth is closed, they're putting more pressure on those retrodiscal tissues. Okay, so again, we talked about this a few times already, but the differential diagnosis, when you see that patient with air quotes or quotation marks, jaw pain, there are a lot of different things that can be at play, and you don't want to miss them. So the simplest thing is take x-rays. The patient can be having dental caries or an abscessed tooth, and you certainly wouldn't want to miss that. If you take a look in the mouth, look for lesions. You can have herpes zoster in older patients. You can have herpes simplex lesions in the mouth, oral ulcers, traumatic ulcers, or others like implantus. All of these things can be causing discomfort in the mouth, which can be radiating to the jaw joints or to the muscles in that area, and you wouldn't want to miss it. The other thing is, again, the autoimmune conditions, so the lupus, Sjogren's, rheumatoid arthritis. All these have sort of different presentations, but you can see oral lesions with lupus. Sjogren's would affect the salivary glands more so, and again, rheumatoid arthritis within the joints can cause significant destruction. Cancer pain, you can have cancer within the jaw bones themselves. Again, metastases, prostate or breast cancer metastases to the jaw, or it can be, again, you can have cancer within the salivary glands. You just don't want to miss anything like that. So again, that cranial nerve exam is important. Looking for any of those nerve deficits can really trigger, and again, accompanied with your imaging, it can really help you to remember those things, or to make a diagnosis for something like that and get it onto the right person for biopsy. Maxillary sinusitis, something you don't want to forget. Happens all the time during the winter months. Salivary gland disorders, again, it can be something as simple as salivary gland stone. So you can have in submandibular gland and the sublingual glands. You can have a blockage along the parotid duct, or you can have something like parotitis, which can cause inflammation and swelling right in that preauricular area. And then, a variety of ways to deal with those things. We don't have to necessarily, as a general dentist, you're not going to be expected to manage those things, but you'll be expected to recognize those things, or at least recognize something that you're not comfortable with, or you don't really have a good understanding of, and then just send the patient on to either a family doctor, or the ENT, who can arrange for a referral to the ENT doctor, or just communicate with your oral surgeon, because we spend a lot of time working with the ENT, the ear, nose, and throat surgeons, with the plastic surgeons, with all the family doctors in the community, especially us, who train in London, and for those trained out of London, it's a tightly knit community, and so we all really are comfortable with one another, and we can get that patient off to the right person. So yeah, just speak with your oral surgeon, and we can sort of take care of that for you if you're not comfortable with it. Neuralgia is something, again, that's important. So trigeminal neuralgia, for cranial nerve 5, or even something like glossopharyngeal neuralgia, not quite as common for us to see, but something that can definitely cause a lot of throat pain. It can refer up to the jaw area. Giant cell arteritis is something that you're not going to be expected to make a diagnosis for, but that's something that can affect the temporal artery, superficial temporal artery, and it's an inflammatory condition. It can actually lead to blindness if not recognized properly. So significant pain up in this area, and a lot of the emergency room doctors will see this. And it's important to at least have a thought of something like that in the back of your mind. If you can't find anything going on, it would be amazing to see that on a referral sheet saying, patient, presents with exquisite pain in the temporal area, and family doctor, for example, measured elevated levels of ESR, these other inflammatory markers. People can miss things. Even a family doctor can miss things. But if you see that there are things going on and you can't find a diagnosis, again, send the patient along to an oral surgeon. We've seen a lot of these things over the years, and we'll have maybe a better chance of picking it up. Primary headache syndrome. So you have the tension headaches, migraine headaches, all these variety of different types of headaches, and those can be confused with TMD. And then we get down to the last three. Sort of take that whole group up from above, which are the less common things, and then we can see the last three that we see a lot of as dentists. So there's the myofascial pain, we talked about the internal derangement, and then the trauma and dislocation, and all those things that we're really sort of the specialists for. So these are the things on the bottom three that the family doctors are going to refer patients to us for, or the ENT surgeons are going to refer to us for. Plastic surgeons, they don't really deal with this as much, and so they really rely on our expertise in this area. So imaging in the general dentist office, the Panorex is the best thing you can do for getting imaging of the joints. And if you can send that along with a referral to the OMF surgeon, then that's very helpful. But a lot of the times we'll end up taking a newer one if it is an older x-ray, because we want to make sure that we're seeing exactly what's going on at that point in time. If the patient does have a dislocation, or if they have anything else going on, we just want to make sure that we're not looking at something that could have changed when the patient's in the chair. The next things that you won't do in your office so much, it'd be more like an emergency room thing, or something that a family doctor might order, is PASF, for example, which orthodontists have those in their office, oral surgeons have those in their office. So we can take those to just get an overall broad look at all the bones in the maxillofacial complex. Or there's something known as the reverse Town image, where the patient presses the head up against the film, and they take the x-ray, and it really highlights the condyles. So here's an example down here, a patient who had a right condylar fracture. So you can see that up here. This image is reverse Town. You can really highlight the condyles, the condylar necks, and look for fractures or anything going on there. It's more for trauma than anything. You can see the patient's already been placed in arch bars, and this fracture is here. And then after going to the operating room, the patient also had a mandibular fracture that was fixed with plates and screws, and again, the condylar fracture was repaired. So yeah, a good image that you might, that an emergency physician or family doctor might order, because that's really within their wheelhouse, those types of images. CT is really the best. I mean, if you have a cone beam CT or a medical grade CT, it gives just the most detail. Really good for surgical planning. So whether the referring dentist or the specialist who sees the patient is ordering it or getting it, it's going to be important, especially for any type of surgery that you do. MRI is something we don't deal with very often in dentistry, but for these internal derangements, you have a lot of information from that. And you really do need it to get that diagnosis. So anytime you send a patient to an oral surgeon with, let's say the most common thing would be a closed lock or an anterior disc displacement without reduction, that mouth opening is limited to, let's say, 20 to 25 millimeters. You want to get an MRI. So in Ontario, oral and maxillofacial surgeons are unable to order MRIs. That's just how the government of Ontario works. They're not letting us do that at this point in time. It's not to say that won't change, but what we do, we basically make the diagnosis without the MRI, and then we'll ask the family doctor to put an order in for that, and then to just forward the results over to us afterwards. And what you'll do is you'll get open and closed mouth views, and I'll show you MRIs in a moment here. And then you can see that disc is in fact stuck forward in the open mouth view, or you can identify a late recapture. So that's important, because if you're going to go to the operating room and make an incision in front of the ear, fold the tissue forward, and take that disc out, you want to make sure that you're doing it for the right reasons. And then we get to arthroscopy. So that's something that would come before surgical intervention, open surgery, we would say. And I have a few slides talking about arthroscopy, where you basically are putting a scope into the joint through the skin in front of the ear into the joint, and you can look around that scope. You have a monitor in the OR, it shows you the images, and you can really diagnose the condition. You can look for adhesions within the joint that are limiting range of motion. You can look for, again, fibrosis, fibrillation, so little, worn cartilage around the joint. You can look for erythema, and sort of signs of inflammation within the joint space. Again, helping you with the arthroscopy, when it's accompanied by an arthrocentesis, which is a flushing of the joint. You flush that Ringer's lactate through the scope right into the joint, and it flushes all those inflammatory mediators out. And that provides a lot of pain relief for the patients and improves their function. So it's both a diagnostic and a therapeutic intervention for them. And so that's why it comes earlier on in the treatment process, before we get to more advanced open joint surgical procedures. So here is an example of just the Panorex. If you look at this here, you'll see, again, you're looking at the broad picture first. You don't want to just focus. You can see something's going on with the joints, but whenever I'm looking at a Panorex like this, I try to stay away from focusing right in on the obvious, and just look around. You can see, no fluid in the maxillary sinus bilaterally. Maybe you could have some caries. I can't really see that with great detail here, but you can definitely see that there's some periodontal disease here, which could be causing some pain. There's definitely at least a shortened dental arch and possibly a deep bite here. So this occlusion could be causing discomfort in the joints. And so that's something to think about. But in any event, you have up here what looks to be the classic signs of osteoarthritis. So you've got a reduced joint space here, got subchondral sclerosis. So below the cartilage cap of the condylar head, you have a radiopaque material here, or radiopaque process going on. So this is just thickening of the bone underneath the cartilage. Again, that's one of the classic signs of osteoarthritis. Then you have these little radiolucent areas within the condyle as well, and you call those subchondral cysts. And then the last thing you would see is the little projections off. They call these osteophytes. So those four things: joint space narrowing, subchondral sclerosis, subchondral cysts, and osteophytes are the hallmark radiographic features of an osteoarthritis. And you can see that over here. It could be a rheumatoid arthritis as well. Again, you need blood work to really differentiate between those two. But yes, here's another image. So anytime you look at an image, you want to sort of think about what type of image it is you're looking at. Here we're looking at a coronal slice of a CT scan. So looking at this, you can see again osteophytes projecting off. Really good view of those subchondral cysts, subchondral sclerosis, and narrow joint space. Here's a sagittal view of a CT scan. And again, you can see an osteophyte. You can see abnormal contour to the condylar head. And this would be in the open mouth position. So yeah, a lot of information there. Here we progress to an MRI. And what we have here is on the top, we have, on the top we have here a disc. You can see it right here, and it's in the proper position. So it's right over between the articular eminence and the condylar head. And then in the open mouth position here, you can see that that disc stays right between the articular eminence and again, the condylar head. On the bottom, this radiolucent area here is the disc, which is anterior. And then in the open mouth view, that disc is bunching up in front of the condyle. And so that patient is going to present with that 10 to 20, or the 20 millimeter opening or so. That's anterior disc displacement without reduction. Treatment. So this is the meat and potatoes of the lecture, essentially, for that small majority of patients with TMD who actually have some discomfort and need to be managed. The first thing you want to do is start them with behavioral management. So look at their diet. Are they chewing crusty baguettes? Steaks that are tough to eat? Those things can aggravate the muscles. Get them to sort of get away from that. Pharmacological management, we'll talk about that in the next slide. Starting with something as simple as NSAIDs can help with this discomfort. Family doctors are really the ones who should be prescribing antidepressants and some of the stronger muscle relaxants. And so I have a slide showing that just referral to them for the pharmacologic management is probably a prudent choice. But starting with NSAIDs is definitely something that we can comfortably do. Occlusal adjustments is again something that you do an assessment, and if they do have a malocclusion of any sort, just getting their teeth to be occluding in a harmonious way can relieve some of that strain. Night guards and splints are always great. You want to have a firm night guard, not a chewy, gummy one. That kind of aggravates the condition because patients will be chewing on it and they'll be going away at it all night long. Sometimes they chew right through the things. So a firm acrylic night splint is really important to have. Again, you can refer to family doctor and an oral surgeon for if you're just not comfortable with any of those things. So this is an algorithm. Just because we're getting a little short on time, I'm just going to sort of blow through this here. But really, the most important thing is right in the center there, that conservative therapy. The top part is just identifying, some of those parafunctional habits. Are they, biting their nails, clenching, bruxing? Just educate the patient on those things and sort of modify those behaviors. That's what we'll always start with for those patients who don't have anything more sinister going on. We always start with these things with conservative therapy. Again, you can talk about stress reduction. You can talk about doing yoga. You can even say try acupuncture, go to a physiotherapist, and they can help massage those muscles. These are really important. And then again, trial of an NSAID, and naproxen is the best one. There's evidence to show that, and I have some RCTs, randomized clinical trials, that show that evidence in the next couple slides. And then the most important thing after that is just to take another look at them, see how they do. Ask them if they adhere to those things you talked about. And then if they're improving, you have that, let's say it was an 8 on 10 to start, and it's now a 3 on 10 after they've done these things, then you can really say that they've improved greatly. And as long as they're okay with that, they don't necessarily need to have anything further done. And that's it. If they don't improve, then that's when you really want to think about referring. And the next set is really just talking about the same things, but then it talks about, again, antidepressants, benzodiazepines. These are things that family doctors will more commonly prescribe. Okay, so when it comes to looking at the literature, you want to make sure you're looking at adequate studies, and randomized clinical trials are really with double blinding, placebo controlled, those are really the best of the best. And you can judge or guide your treatment based on the results of those studies. So for this table here, it's showing 4 different studies that all looked at different NSAIDs for the management of TMD. So Celebrex, diclofenac, ibuprofen, naproxen, piroxicam. I've never actually seen that one prescribed here in Canada. But in any event, of all of these, naproxen 500 milligrams 2 times per day was the only one that showed a statistically significant reduction in pain. And so that's important to think about when you're trying to start those patients on an NSAID. I would go with naproxen. For muscle relaxants, cyclobenzaprine, it used to be known as Flexeril. I think it's no longer made under that name, but 10 milligrams every night was shown to have a statistically significant reduction in pain. As a general dentist, or even the specialists out there, you may want to stay away from prescribing cyclobenzaprine. You can leave this up to the family doctor because there's a lot of interactions that you can have with this medication. If they've had any recent seizures, or if they've had cardiac conduction disturbances, arrhythmia, recent MI, stroke, all these other things, it can cause some side effects, and you don't want to get into that. So it's important to remember this medication and possibly advise a family doctor or the oral surgeon, say, hey, what do you think about using something like cyclobenzaprine? That would be more prudent than prescribing yourself if you're not really comfortable with this type of medication. The other thing you can do is you can advise the patient to use over-the-counter muscle relaxants, so that like Relaxacet, that you can buy at Shoppers Drug Mart. That's a great one, and they can use that and follow the instructions, and there's no sort of liability on your part for saying, if you want to buy something over the counter and try it, follow the instructions on the box. But if there are any contraindications to that, then the patient should not be using that either, just as with any medication. Then it went into looking at benzodiazepines. Again, we're not really going to be prescribing something like triazolide to patients, or Ativan, something a family doctor might do. But the study showed that really Valium at that point in time was the only one that statistically significantly reduced pain. So again, you can point patients in that direction and ask the family doctor if they saw that study. You always have to be a little careful when you're sort of showing how much like that, but if the patient's not having any help with that, then you want to keep that in mind. Then we get into gabapentin, a calcium channel blocker, and amitriptyline, which acts on serotonin and norepinephrine, and it's a reuptake inhibitor for those two. Again, these two are really effective, and you'll see a lot of patients coming in for any chronic pain condition on these medications, and these are medications that their family doctor can prescribe for TMD. So summary slide for that. When we see patients as dentists, thinking of naproxen 500 milligrams twice a day, during that conservative management or non-surgical management side of things is really important to get them on, because that helps reduce that inflammation, helps get them sort of out of the woods, helps things to sort of heal up a bit while they're avoiding the difficult to chew foods. Maybe they're trying yoga, doing acupuncture, things like that, physiotherapy. And then when you see them that next time and they've improved greatly, you really, sometimes you don't need to progress much further than that. And they can get off the naproxen once you've gotten them out of the woods and things have healed up a bit and they've now changed their behaviors. Then they won't necessarily get back to the same point that they were before. Something I didn't include on the slides is actually Botox injections into the muscles. That's something that can really help. It's pharmacological behavior management. And that's something that we as oral surgeons do. So that's something for the patients who can't get off the naproxen. They've modified their diet. They have a night guard. They can't stop clenching and grinding. But send it to the oral surgeon. We can potentially try something like that with Botox. And then the other medications we talked about, I would just refer to the family doctor with the complaint of TMD to possibly try some of those medications. And again, serotonin syndrome, we won't talk about that, but that's just, again, one of the things that you can cause with those medications. So
we have about 5 minutes. Sorry to interrupt there, but about
perfect.
5 minutes before we have to move on.
Okay, perfect. So we'll just sort of blow through the last ones here. We might have to skip the cool surgical pictures, unfortunately, but I think we've got through the meat and potatoes of the the information here. So if you see a patient with trauma or fracture to the TMJ complex, that can be an immediate referral. They fell off their skateboard, fell off their bike, hit their chin on the ground, significant pain started immediately afterwards. Maybe you get a panorex, you see something going on. That's something you don't have to do conservative management with. You want to get that patient in either to the emergency department or to your nearest oral surgeon so they can take care of that. Again, a dislocation, if you're not comfortable with reducing those, then send along to the oral surgeon. Recurrent dislocations, you can do surgery for that and fix that. We're not going to be able to show the slide for that, I don't think. Again, if you tried conservative measures and it just hasn't improved, then again, refer on to the oral surgeon. Or anything that's really lasted longer than 3 months or 6 months and maybe it's improved a little bit, but it's still bothering the patient, that's a good time to send on to the oral surgeon. So these are just some of the various surgical options. Again, the arthroscopy and arthrocentesis we talked about. Aminoplasty is for recurrent dislocations. Discectomy is for the chronic closed lock. Total joint replacements more for those chronic osteoarthritis or rheumatoid arthritis patients, or maybe even some of those congenital abnormality patients who just have no joint to function on. And costochondral grafting is an alternative to the actual alloplast used, the prosthetic used. Lots of different complications for open surgery. Don't need to see that. Cool picture showing arthroscopy here. You see the little camera in the OR. You're looking directly at that while you're manipulating the scope in the joint, and you can flush it out. You can see some adhesions here. You can see some, erythema and other signs of inflammation. And again, that's something the oral surgeon can take care of. This is just an interesting case where patient had recurrent dislocation, did a CT scan, and you realize that it's pneumatized in this area of the articular eminence. And so you don't want to do an aminoplasty and shave that down because then you can expose the craniofossa, and that's not good. So what you can do is a modified Leclerc de Tray procedure where you actually fracture the zygomatic arch down, or you can cut it precisely and use plates and screws to create a new eminence that blocks that dislocation. So very cool surgery, and you can create that blockage so that they don't chronically dislocate. And there it is there, the post-op. Here's another patient. Again, example of a tumor that a patient could have. This patient came in with recurrent ameloblastoma. You can see that in the left choroid process and ramus here. And this is the planned resection margins. So went in and had custom-made alloplastic prosthesis. This was one that I actually worked with David Supka in Toronto during my GPR before oral surgery. I also did rotations with him during my surgical training. But this is the specimen removed. This is a histology showing those classic features of ameloblastoma, that reverse polarization, hyperchromatic basal layer. Then you can see the prosthesis in place. There's screws. There's also a hip graft here, so we could have implants down the line. There's just some plain film imaging, really shows that nicely. And there's this functioning. This guy, it's hard to imagine, based on that small little scar there, that he has that whole prosthetic unit going on under the skin. And his function is fantastic. He's a very happy man after that. So again, just to summarize, thorough history and physical and imaging. Start with a conservative therapy. You can try naproxen. You can refer to a family doctor for the blood work to look at autoimmune things, pharmacotherapy, or advanced imaging like CT or MRI, or an oral surgeon can do those things too. Or if you just see trauma, fracture, dislocation, pain that's not responding to conservative management, or pain with no identifiable source for greater than 3 to 6 months, get him or her off to the oral surgeon. We'd be happy to help you out. I'm personally not seeing a lot of TMJ patients at this point in time, but my colleague, my friend, my mentor, Dr. Michael Shimizu at London Health Sciences Center is really the TMJ specialist of Southwestern Ontario. In Toronto, Dr. David Supka is a fantastic surgeon. So if you have any surgical issues for patients, I would recommend for this point in time, Dr. Michael Shimizu. But again, I'm always available. I'm working here in London, and I'm just starting out. Just graduated 2019, so I'm always happy to be meeting new dentists, meeting new people in the area, seeing patients of any sort. But that's it. So yeah, here's Jaws, the patient from the beginning of the lecture. Look at him. He went through his conservative therapy. He took off he had some occlusal adjustments perhaps, and stayed away from the baguettes and steel wires. And now he's doing a lot better. So that's it for me. Thank you sorry if I went a little over time there, Hisham.
No problem at all, my friend. Thank you so much for that.